previously done 2 sessions some several months back on anatomy and physiology of eye movements. So now it will be the part 3. As you know, eye movement is like everything else in neurology, is a vast subject. And standard textbook is Eye Movement Disorders by C. and Lee. From that, it's a book by itself. And I have taken the digested gist of the eye movement control. And the first 2 parts the students can go through once again. So you know what is the anatomical basis. That's the class 1, and physiology with synthesis of various movements. That's the part 2. You see, the eye movement is the end product of vestibular system, Vergence system, Saccadic system, pursuit system. And these systems, they get their feedback from the proprioception, labyrinth, then attention, orientation, parietal lobe, sensory information, and cerebellum, basal ganglia. These all contribute to the final formation of saccade, pursuit, and Vergence. And a combination of all this through the oculum are channeled through the cranial nerve nucleus, cranial nerves, and the extraocular muscles to get the precision of the vision that we get. This I have covered in the previous 2 sessions. That is called synthesis of eye movements. Synthesis is a complex process involving muscles, nerves, their nuclei, the brainstem connection, that is the neural integrator, and the neural integrator in turn controlled by the cerebellum, basal ganglia, and cortical motor structures. A combination of all these together gives us the precise vision that we have. If any one of them get disturbed in this circuit, eye movement will show appropriate aberration in the synthesis, resulting in various disorders. So this is the part 3. So quickly I will revise. I will not be going through the rest that you will have to revise. Of course, it is some months now. So you will have to refresh it again. Okay, so why do we need an eye movement? It is to bring the target of interest to the fovea. Only if the image falls on the fovea, we will have no blur. And to shift the line of sight in a need-based way. So target should fall on the fovea. And if you want to shift our gaze from one target to another, that also has to happen. That happens by the eye movement. And to oppose the viscous drag of the orbital content. So when we want to move the eyeball, we have the connective tissue, the fat, and all those things inside the orbit. So the movement should oppose the viscous drag of the orbital content. It should focus on the target, and it will also should shift the line of sight in a need-based way. For that, we need a eye movement. Even though we have got an optic nerve and its connection for vision, eye movements are important. For that, these are the various systems. One is the vestibular system. I have elaborately dealt with. Briefly, I will cover this so that it becomes easy. Vestibular system holds image of the seen world steadily on the retina during brief head rotation. You know, it is contained in the fluid, endolymph, in the labyrinth. So uniform oscillation in a fluid column will produce inertia. Because of this, after brief head rotation, vestibular system will stop reacting. That is why for brief head rotation only vestibular system is useful. For sustained head rotation, we have the optokinetic system. Next is the visual fixation that holds the image of a stationary object on the fovea. Then optokinetic system holds images of the seen world steadily on the retina during sustained rotation. During brief rotation, very quick to start, that is a vestibular system. But after some time, it will stop responding. Then the optokinetic system takes over for sustained. It has got a longer initiation time. Optokinetic system is slow to initiate, but it is steady. The smooth pursuit holds the image of the small moving target on the fovea. So smooth pursuit is a follow-up movement. If there is an object that is moving, we need a pursuit system to slowly follow. Nystagmus quick phases is the saccade. So normally also we have nystagmus. When you are traveling in the bus, you watch the eye of the person in front of you, you will see nystagmus. So what does this nystagmus? The physiological movement resets the eyes during prolonged rotation. When you are moving in the bus, then you know that the environment, trees will be there, houses will be there. They are undergoing continuous prolonged shift in the gaze. So to bring the eye to the next target, you have seen one coconut tree, the bus is moving, next you are seeing a mango tree. So the eye has to be brought back. For that, the quick phases of the nystagmus is used. And saccades bring images of object of interest into the fovea by fast movement. It does not need a follow-up target. It is a quick movement. And Vergence moves the eyes in opposite direction so that images of a single object are placed or hold simultaneously on both fovea. So Vergence is a disconjugate movement. That is, both eyes converge or diverge to bring a centrally placed object in both fovea. So these are the various classes of eye movements. And what are all the types of target? Anticipated target. So when you are moving in the road, you anticipate buses, scooters, cycles. Unanticipated target, an animal quickly coming across the road. It's an unanticipated target. And you may have moving target. You may have non-moving targets. So these are the various targets. Anticipated targets, we have got set protocol based on that our system will move. Unanticipated target, novel target recognition system will come. Moving target, we have the vestibular system, optokinetic system, and the pursuit and the saccade. And stationary target, we have got the visual fixation. Then what are all the terms used for the eye movement? What is the term duction movement? This all I have elaborated in the first two sessions. This time I am giving a gist so that we will be able to follow those who have not revised the first two sessions. So duction movement refers to monoocular movement of each eye. Each eye moving, that is the duction movement. Version movement refers to binocular movement, conjugate movement. You look to the right eye moves outside and the left eye moves inward. That is the version movement. So version refers to binocular conjugate movement of both eyes such that the visual axis of the eye moves in the same direction. That is version movement. Vergence movement refers to binocular disconjugate movement. So binocular conjugate movement is version movement. Binocular disconjugate movement is vergence movement. And uniocular movement is duction movement. And then the end organ which carries out is the muscles. As you remember about the eye muscles, one is the recti. The recti act better in the abducted eye. So if you are checking a recti, you always check in the abducted posture. So recti act better in the abducted eye. Obliques act better in the adducted eye. Superior muscles, that is superior rectus and superior oblique. Superior muscles, not superior recti. Superior muscles intort. This, if you by heart, you know the end muscles which carry out the various movements. And the inferior muscles, that is inferior rectus and inferior oblique, extort. Vertical recti, superior rectus and inferior rectus, adduct. Vertical oblique, that is superior oblique and inferior oblique, abduct. So next is the innervation peculiarities. Superior rectus nucleus, you know the Warwick's model of the third nerve nucleus. Superior rectus innervates the contralateral superior rectus muscle. And the superior oblique, that is a fourth nerve, normally crosses dorsally in the brainstem and supplies the contralateral superior oblique. And levator palpebrae superioris has got bilateral innervation. Single nucleus is supplying both levators. So if there is a nuclear third nerve palsy, if there is a ptosis, it will be always bilateral. If there is unilateral ptosis, it is not nuclear lesion. And Edinger-Westphal subnucleus is a single structure that provides parasympathetic innervation to both sides. So these are some unique features of the extraocular muscles. So this is the diagrammatic representation of the various muscles. You can see superior muscles, they will intort. Inferior muscles, they will extort. Vertical recti, they adduct. Vertical oblique, abduct. Medial rectus is medial movement, lateral rectus is lateral movement. Then we will see this is the first level. First level structures are the extraocular muscles and the oculomotor nerves that supply these muscles. Second level is the brainstem, where we have got PPRF, medial longitudinal nucleus, nucleus of Gajal, rostral interstitial nucleus of MLF, posterior commissure. And these are linked together, that mainly the perihypoglossal nucleus, medial vestibular nucleus, and the horizontal gaze, that's a PPRF. Together they form a thing called neural integrator. So these are the muscles and the nerves, and these are the structures in the brainstem that link these muscles and the nerves. And this linking is fine-tuned by a monitor, that is the neural integrator. Neural integrator is like the corticospinal tract doing the kinetic melody. So neural integrator will say how much you hold on a target, how much you move away, that is by the neural integrator. A neural integrator for this is horizontal gaze. Neural integrator for the vertical gaze is nucleus of Gajal. And these on the alerting system, these are linked to the alerting system, that is a reticular formation, and superior colliculus for novel target. I said unanticipated target or the novel target recognition is by the superior colliculus. So that is the second level structures. Third level is cortex. That is the frontal eye field, parietal eye field, and occipital eye field. And accessory structures, they are the vestibular system. They give information regarding the basal position of the eye so that it is corrected. Then the cervico-collicular system and cervico-ocular system. So these are the various level in very brief thing. So then now I have gone through the vestibular control in elaborate way in the second talk on eye movement. Still I am putting a gist here. You know that the anterior semicircular, these are all important for the different types of eye movement abnormality we get in the brainstem disease. So anterior semicircular canal is joining the superior vestibular nucleus. We know that there are 4 vestibular nucleus: Dieter, Schwalbe, Beck-True, and the superior nucleus. So the anterior canal goes to superior vestibular nucleus, then it crosses across through the medial longitudinal fasciculus to the opposite third nerve. So right anterior semicircular canal will link to the right superior vestibular nucleus and go to the left side third nerve and connects to the left side inferior oblique. Inferior oblique, what is its action? Inferior muscles extort. And vertical oblique abduct, vertical oblique abduct, and inferior oblique is an elevator. So it is an elevator and an extorter. So it goes to the opposite third nerve and supplies the opposite inferior oblique muscle, and then crosses back to the ipsilateral third nerve and supplies the superior rectus. So anterior semicircular canal, the common function is elevation by supplying the ipsilateral superior rectus and contralateral inferior oblique, but vertical recti adduct and superior muscles intort. So superior rectus is an intorter, inferior oblique is an extorter. The common action is elevation. Next is the posterior canal. It goes to the medial vestibular nucleus, crosses to the opposite side and supplies the opposite inferior rectus. We should apply the principle inferior rectus is a depressor, vertical recti abduct, and inferior muscles extort. And then comes the ipsilateral side and supplies the superior oblique of the same side, that is the fourth nerve. So what is the common action? Depression. So posterior semicircular canal has a common action of depression, plus one is an extorter and another one is an intorter. Then the horizontal canal goes through the medial vestibular nucleus to the opposite sixth nerve, supplies the lateral rectus and crosses back to the ipsilateral third nerve, supplies the medial rectus. So it moves the eye to the opposite side. So supposing one labyrinth is destroyed, that side anterior semicircular canal, posterior canal and horizontal canal is non-functional. So let us imagine this canal is non-functional. Then what happens? The various links we saw: anterior canal, is an elevator. Posterior canal is a depressor. Horizontal canal moves the eye to the opposite side. Here what happens? When one labyrinth is damaged, there is no push-pull between both labyrinth. One labyrinth is damaged by labyrinthitis or vestibular neuronitis. What happens? Normally, both have a gain. Right and the left function by a gain. When the gain is 1, the eyeball moves in a versional manner. So now one is destroyed. So what happens to the normal eye? The elevation and depression are getting cancelled. The horizontal movement is unopposed. The push-pull is not there and that becomes 0. So the horizontal canal is not opposed by this canal. So the eye moves slowly towards the diseased side. The vertical movements are cancelled. Torsional movements cannot cancel. So you get a horizontal and rotary nystagmus. So pathomechanism of a vestibular dysfunction producing horizontal rotary nystagmus is by loss of gain and loss of push-pull arrangement between both labyrinth, resulting in eye getting shifted to the side of the slow component is by the horizontal unopposed canal. The vertical movements gets cancelled and the torsional movement remain, resulting in a horizontal rotary nystagmus. So that is the mechanism. So now we'll go to the saccadic system quickly. It is the fastest with a short refractory period and it reacts to one stimuli at a time. And initiation time is about 200 milliseconds. And saccadic pulse is carried out by the burst neuron, saccadic step by the tonic neuron, and there is a pulse step match. Pulse is the initiation energy. And according to the degree to which the burst neuron fire, there is a mathematical relationship between the burst neuron and the tonic neuron. So that decides how much you stay at that target. Then you got pars neuron that inhibit the burst neuron tonically. So it inhibits the opposite side burst neuron. And burst neuron, you have got medium head, large head. Medium head time locked to all fast time moment. Large head codes the direction. The medium head is the time coding and large head burst neuron is the direction, right or left. And tonic neuron discharge in relation to the eye position command and gives the step innervation. And the higher control for the saccadic system is the fronto-mesencephalic pathway. These things I have done elaborately, you can go through. And saccadic accuracy, if there is affected, we saw that there are neurons which time code it, there are neurons which decide the direction, and there are neurons which decides how much it stays. So when there is a mismatch, saccadic accuracy becomes defective. So it may be hypometric, that it stops short before reaching the target, or hypermetric, it overshoots the target, or it can be slow velocity, or it can be a pulse defect when there is a delay in the initiation. So pulse step innervation. So pulse is impaired means delayed initiation. Step is impaired means gaze evoked nystagmus. That is, the object reaches the target. Eye reaches the target, but it does not remain there because step innervation is defective. So it comes back. And pulse step mismatch. So pulse is there, step is not there. So continuous movement of the eyeball. Instead of staying there, it keeps on moving. That results in the type of movements called opsoclonus, ocular flutter, macro and micro square wave jerks. Next is the pursuit. So we saw the vestibular system, we saw saccadic system, abnormalities. Pursuit system is for continuously moving object following, and it can also be for a viewing of an imagined target. You can have hallucination. If there is a hallucination, patient can follow the moving hallucination with a pursuit. And it is the pathway is the pareto-occipito-mesencephalic. Saccade is fronto-mesencephalic. Pursuit is pareto-occipito-mesencephalic. And pursuit system has got an amplitude, direction, and balance. If the amplitude of the pursuit is reduced, it takes the help of the saccade. I told that the eye movement ultimately is the synthesized product. If the pursuit is defective, it takes help from the saccade. So instead of a smooth following movement, multiple saccades will come. So that is called a catch-up saccades. So it's a cog wheel. It will move like a cog wheel. It will not move smooth because the smooth, slow pursuit is not there. Instead, multiple saccades are making it as a cog wheel. Many students send me doubts regarding why this movement, why that movement. Please listen to all this, then you will understand. It is a breakdown of the synthesis of the eye movement. And direction, I said that the medium head burst neuron decides the direction of the saccade. So if the direction is abnormal between both sides, you get different kinds of nystagmus. One is the drift sign of Gay. When there is a frontal lobe disease, the frontal lobe pathway is reaching the medium head burst neuron in the brainstem. If it is defective, when you do the optokinetic tape, normally you get an optokinetic nystagmus, like what we get while traveling in the bus. Instead, the eye keeps on drifting in the direction of movement of the tape. That is called drift sign of Gay. During down or upbeat, it doesn't stay there, resulting in downbeat or upbeat nystagmus. That is when there is an abnormality in the direction of the pursuit. Sometimes when the balance between the pursuit on both sides is lost, then when the eye has to follow the object which is moving to the right side, the eye will move to the left side. That is called inverse pursuit. So these are the abnormalities of the pursuit system. Vergence system is the slowest eye movement. It is non-parallel and it brings the target to maximum focus binocularly. And it can be convergence where you have got a fusional vergence where the vision is not needed. You can use only both medial recti and its nuclei and produce a fusional vergence in a blind eye. And you have got an accommodative vergence where vision is needed. It goes to the occipital lobe, from the occipital lobe to the long association fiber to the frontal lobe, then frontomesencephalic. So accommodative vergence has got a pupillary component, visual component, and an eye movement component, whereas fusional vergence has no visual component. So integration, let us imagine your target is there and the target is not fixed on the fovea. Then what happens? The target moves in the retina. That produces a retinal blur. So the image becomes blurred. So that blur is the stimuli to say that the eye movement has to be corrected to make the object bright. So when the movement slips on the retina, there is a retinal blur. This blur is carried to the area 7, which is an attention area. Then it goes to the peristriate area, area 8. From there, signals are sent to the brainstem for the oculomotor nucleus to bring the object to the fovea. So that is the synthesis, brief phenomena of synthesis when an object blurs. Then you have got, if there is a novel target, as a fly suddenly coming into your eye, then it is sensed not by the visual pathway, but it is not by the retinal blur. It is by the superior colliculus. So superior colliculus recognizes novel target without conscious appreciation. And head position change is recognized by the vestibular input, which we have seen. Neck position by the cervical proprioceptive. Motor coding of movement by the premotor area. Motion and depth perception by the medial temporo-occipital regions. So now we will come. So quickly I revised the first 2 talks which I have done elaborately. Now I just made a gist so that you can follow this session. So how are you going to evaluate the time-tested old caloric test to know whether the brainstem is working in a person who is comatose? If the caloric test is not responding, then means the brainstem is damaged. So how do we do that test? Head is inclined to the pillow at 30 degrees. That makes the horizontal canal apparently vertical. When you incline the pillow to 30 degrees, the horizontal canal reaches a vertical position, and the impulse travels through the semicircular canal, goes to the vestibular nucleus, ipsilateral gaze center, and contralateral gaze center. So if you put ice cold water to the external ear, about 0.4 to 1 ml, it lowers the tonic firing at the ipsilateral canal. Because from the canal, it goes to the vestibular nucleus. We saw the connections. Then ipsilateral gaze center, that is PPRF, and contralateral gaze center. So ice water lowers the firing at the ipsilateral canal and excites the ipsilateral PPRF. And it inhibits the contralateral PPRF. So this produces an imbalance at the gaze center. So when there is an irritation of the PPRF will move the eye towards the side to which the irritation is coming. So if you inject into the right ear, the eye will come to the right side. And eye is pushed to the side of cold water injection because the ipsilateral PPRF is irritated. Irritative lesion of the brainstem PPRF will move the eye to the same side. Paralytic lesion will move the eye to the opposite side. So with the cold water, the PPRF get irritated and eye is pushed to the same side of cold water injection, and corrective nystagmus happens to the opposite side. So this is the normal response we are expecting. If there is a no response at all in a comatose patient, that means the brainstem connections are not there and there is a severe injury to the brainstem structures. Then various ENT causes, there are different responses. So this is one basic test, time tested, done from time immemorial to assess the eye movements. Then you got the Dix-Hallpike test. Patient looks ahead and head turned to one side, then quickly taken to the head hanging position, and then the posterior semicircular canal becomes parasagittal. So for the Caloric test, you use the horizontal canal, this Hallpike test, posterior canal, and then you keep it in that position for 1 minute. Normally, you will get vertigo and nystagmus. So that is Hallpike test. Then then you are going to ask questions at the bedside. Is my patient having a problem with eye movement? And if there is an eye movement problem, is it physiological or pathological? And if it is not physiological, it is congenital or acquired. And if it is abnormal, is it intranuclear or infranuclear or nuclear? So is it taking place in the infranuclear means we saw the muscles and the nerves, and the nucleus is in the brainstem. So is the eye movement happening at the level of the muscles and the nerves or at the level of the nuclei? Then if that is not there, is it supranuclear? You have got the supranuclear connections for the various oculomotor nerves. So is it supranuclear? Is it restricted or combined? Is it involving one muscle, one eye, one nerve, one nucleus, or one gaze center or both centers? And what are the abnormal eye movements seen? And is it possible to localize them? And is it possible to treat them? So these are the questions when somebody presents with an eye movement problem. So, and abnormalities can be peripheral disorders of ocular motility or central disorders, that is nuclear and supranuclear. And symptoms of an eye movement problem can be patient may present with a squint, patient can present with a double vision, patient can complain of abnormal eye movement, patient can tell about head tilt, they can have head thrust, head nod. To fixate the object, they may have head thrust, they may have head nod, they may have blurred vision, or they may have shaky vision or oscillopsia, and they may have abnormal eye movements which are visible. So let us see a patient who is reporting with a squint. Then you have to know, is it paralytic or not paralytic? If paralytic, which structure is responsible? Muscle, myoneural junction, nerve, supranuclear, nuclear, interaxial fascicular, cisternal, skull base, foraminal, or soft tissue plane. So in which plane is the eye movement affected? Now let us, these are the questions. So now we have to find out the answers. Let us imagine a patient's squint is congenital. What will be the features? Putting the questions that I have just told, you put those questions and try to find out. Patient may not know that he is having a congenital squint. So you have to decide, because if a patient reports with a new onset squint, the differential diagnosis is going to be different. If it's a congenital squint, you are going to leave it off. So if the patient doesn't know, we will look at their photographs, old photographs, and it will be long duration. And some family members also may have the same squint. Usually it runs in families, and often this congenital squint is non-paralytic. So eye movement will be complete and rarely paralytic, like Duane's retraction syndrome or brown superior oblique tendon sheath syndrome. These are the rare paralytic congenital squints. Otherwise, the congenital squint is non-paralytic. And other features like divergence and convergence during vertical movement, they are pathological synkinesis. What happens? A person with a congenital squint, you tell the patient to move the eye up. When he tries to move the eye up, instead of moving vertically up, it might converge or it might diverge. That means there is a pathological synkinesis at the nuclear level, which is by birth. So these are the points: long duration, family members showing squint, non-paralytic generally, and during various eye movement testing, you find pathological convergence or divergence indicating a developmental linking of the nuclei in a pathological way by birth. So now somebody is coming. So first symptom is a squint. We have analyzed that. Next symptom is the double vision. So if there is somebody telling double vision, find out whether it is intermittent or constant. Intermittent double vision, we know that you get it in neuromuscular junction disorders, and sometimes you get intermittent double vision in some kind of central pathologies also. Whether it came suddenly or slowly, is it horizontal double vision, vertical double vision, or both? And what are all the other accompaniments? So a patient with double vision, you will ask these questions. Is it intermittent or constant? Is it sudden or slow? Is it horizontal or vertical? And what are the other accompaniments? Then we have identified, is it vertical, horizontal, combined? Is there is a head tilt? If a person with double vision has got a head tilt, normally only two. Lateral rectus palsy will produce ipsilateral head tilt, and superior oblique palsy will produce a contralateral head tilt. It's a compensatory null position adaptation, because these two muscles produce a position in which the double vision is maximum corrected. So that is the head tilt compensates for the double vision. Then next look at the, so look, see if there is a head tilt. And then look at the resting eye position. How are you going to look at the resting eye position? You need good light, and you examine straight forward. And then if there is a paralytic squint causing diplopia, there will be an abnormality in the resting eye position. Like what we see, lateral rectus is paralyzed, then the eye will be more medial. Medial rectus is paralyzed, the eye will be more lateral. And then check the eye movements in 6 cardinal planes: superior, inferior, lateral, medial, and oblique. Then turn patient's head to observe different gaze position. Then patient head movement is done to find out the version movement. Is the version all right? Then what is crossed diplopia? Horizontal diplopia, in which the false image is coming from the contralateral eye, and it is inner and indicates exotropia. That is usually seen in medial rectus palsy, and where the false image is inner to the true image on the side of pathology. So that is the crossed diplopia. Then we see the bedside assessment of deviation. You can put a torch light from below and see the reflection in the cornea. Normally it will be symmetrical. If in one eye it is eccentric, that indicates a subtle squint. Then you can do the cover test and alternate cover test, and you can use the Maddox rod, each color for each eye, and see whether there is a maximum separation of one image, that is the will correspond to the false image. Then head tilt to the affected side in lateral rectus, opposite side in superior oblique, and elevation or depression if there is a vertical muscle paralysis. And you see third, now let us see the third nerve palsy. That is one cause for double vision: drooping of eyelid, dilated pupil, divergent squint, and double vision. So this is classical diplopia due to third nerve palsy, 4Ds. What is cover test to unmask a mild paralysis? So first find out and to know whether it is a paralytic or non-paralytic. So when you look at the resting eye position, there is a disconjugation that is called the primary deviation. So when an extraocular muscle is weak, eye deviates in the direction of the active antagonist. Like what I said, right lateral rectus is weak, eye will move medially, whereas the left eye is normal. So there is a non-parallelism of the visual axis, and that is the primary deviation. Secondary deviation, you cover the normal eye, cover the left eye which is normal, and patient fixed with the paralytic eye. So when the patient fixes with the paralyzed eyes on the target, the eye puts a lot of energy to move the paralyzed eye. There is a principle called Hess principle, which also I have discussed in the previous 2 sessions. By Hess principle, yoked muscles, eye muscles which carry out a particular action get equal amount of energy. So when you fix with the paralytic eye, more energy is given to the paralyzed eye, but the same amount of energy is given to the non-paralyzed eye on the normal eye. So with a good amount of energy, the paralyzed eye will move little, whereas the normal eye will move much more. And this deviation is the secondary deviation. So resting eye position shows the primary deviation. And when you fix with the paralyzed eye, the extra deviation is the secondary deviation. So if there is a secondary deviation, it indicates it is paralytic squint. If the secondary deviation and the primary deviation are same, that indicates it's a non-paralytic squint. Then alternate cover test is sometimes patient will tell, I am having double vision. Routinely you check all the eye movements, you do not find anything. So it may be you are confused whether the patient is malingering or not. So it is done to unmask a subtle extraocular muscle palsy. So cover the normal eye, non-paralytic left eye. So the paralyzed right eye slides. So imagine right eye is paralyzed. So you just cover the normal eye and patient fixates with the paralytic eye. Then you will find that there is a slight movement of the paralyzed eye and little more movement of the non-paralyzed eye, which can be measured even if the eye is closed. And this movement of redress is the primary deviation. Then cover the paralytic eye and the normal left eye also moves to fixate. This is the secondary deviation. So alternate cover test is continuously alternate between both eyes, so that when the patient tries to fixate on the probably sick eye, there is a mild deviation, that is the primary deviation. And then when he fixes on the normal eye, there is another deviation, that's the secondary deviation, which says that the patient is not malingering. He is truly having a subtle oculomotor palsy, which we are not able to see when you are not doing the alternate cover test. So you have to need a good illumination. Patient sits eye to eye with the examiner, observe resting eye position, turn patient's head to observe different gaze position, and duction movement is individual eye movement, and assess maximum separation of images. So let us see a vertical diplopia patient. So we see type of double vision, whether it is vertical or horizontal. Horizontal means very easy, 4 muscles, medial rectus, lateral rectus of right eye and left eye. Very easy, in whichever direction it is deviated, you know, and cross diplopia is for medial rectus. Vertical means you have got 8 muscles. So that is right superior rectus, right superior oblique, right inferior oblique, right inferior rectus. Same kind of muscles on the left side. So 8 muscles. So move the eye in cardinal positions with a red gloss to one eye, and find the plane in which the maximum separation takes place between the red gloss and the other gloss in the opposite eye. And what is this forced duction to test tethering? This is no more done. In the olden days when the advanced investigations are not there, supposing there is a tumor producing angering of the eyeball, or a paralyzed eyeball tonelessly jutting out, producing a proptosis. To differentiate that, conjunctiva will be anesthetized and slightly mechanically pull the eye. If there is a tumor, the eye cannot be pulled easily. If there's a paralysis, it can be pulled. That is called forced duction test to know whether there is an orbital tumor or an orbital muscle paralysis producing a mechanical proptosis. Then what are all the signs in Myasthenia gravis? You see curtain sign. You hold the eye, somebody presents with the drooping of eyelid, and you tell the patient to fixate on your hand for minimum 5 minutes. slowly the eyelid comes down. That is called curtain sign. Second important point, it's an allergy failure. It is not a paralysis. So within the range of movement, patient can generate fast movement. Whereas a patient with an ocular myopathy, where there is no movement, it is not an energy failure. So that patient cannot generate saccades. And next is the plus minus sign. When you close one eye, the opposite eye elevates because the maximum energy is focused on one eye. That is called plus minus sign. Yawning sign or peep sign. Tell the patient to keep the mouth tightly closed. After some time, the lip slightly opens. Then Kogan's eyelid twitch sign. That is, you tell the patient to fix on a target below. Fix on a target below and slowly bring the finger up. So when you fix on a target below and slowly bring the eye up, what we are doing, we are holding back. Yeah, even though the command is to open the eye, opening is held back to match the speed of the moving finger. So it is actually holding back. So the opening eye fatigues early. So when you do this slowly, halfway through, patient can no more slowly follow the eye movement. Instead, he'll pop. That is called Kogan's eyelid twitch sign, which is another important sign in myasthenia. And you can get a pseudo internuclear ophthalmoplegia. And you do the ice pack on the eye for 5 minutes. That's the simplest test. And the oculomotor symptoms improve. And you got the neostigmine test and the hydrophonium test. Hydrophonium is not available. So these days we do the neostigmine test. So this is the classical plus minus sign. When the left eye is closed, the right eye opens. When the right eye is closed, the left eye opens because available energy is channeled to the one eye when other eye is mechanically closed. So then test for VOR. That is vestibulo-ocular reflex. That is a reflex movement, version movement. So first you find the acuity by the Snellen's chart and ask subject to fixate on the smallest visible letter, and then you move the head horizontally at 1 hertz per second. So patient fixates on the smallest letter and you move the eye mechanically and about 30 degrees to either side. Then in the vertical and horizontal plane, if the acuity, if the VOR is normal and patient is fixing on the smallest letter, there will be no blur because the VOR adjusts and fixates the eye. So that is a test for VOR, that is vestibulo-ocular reflex. Is it all right? Is the gain normal? Is the labyrinth functioning normal? That is, you fixate on the smallest letter that corrects for the best acuity of the patient. Then hold the head and move 30 degrees this side, 30 degrees like this. And patient is fixating on that and the acuity does not fade. That means VOR gain is 1. Then use the optokinetic tape and look for the optokinetic movement. There are so many abnormalities that I will be showing. Then ophthalmoscope, you can look for the nystagmus, which is very subtle in the disc. With ophthalmoscope, when you look at the disc, you will see the disc is oscillating. Then we have got the oculocephalic test. In conscious patient, oculocephalic test is little difficult because patient might voluntarily move the eye. So you can tell the patient to fix on an object and move the oculocephalic. But in a comatose patient, it is easy and it tests the integrity of the brainstem. So now let us see the next level. We saw the muscles and we saw the labyrinth and we saw the neuromuscular junction disorders. Now we are coming to the brainstem. We saw the various levels in which diseases happen. So first level grossly covered, diplopia, squint, myasthenia and VOR. Now we are coming to the second level, the brainstem. There the most important thing is the medial longitudinal fasciculus. It produces an internuclear connection of supranuclear nature. And it's a non-vestibular pathway among the cranial nerve nucleus. And sixth nerve, ipsilateral and contralateral third nerve are the ones which are linked, which I showed through the various connections of the various semicircular canal and how they connect through the MLF, crossing to the opposite side and coming to the ipsilateral. So contralateral third nerve and ipsilateral sixth nerve. is connected by the MLF. And it is also having inputs from the eye, ear, neck, and limb extensors. So that is medial longitudinal fasciculus. And this is a person who is having failure of adduction in the left eye, and she is having nystagmus in the abducting eye. This is not a video, so the nystagmus is not seen. She has failure of adduction in the left eye and nystagmus in the opposite eye. That is the typical feature of a MLF involvement. What happens, as I said, MLF is not nuclear or infranuclear. We have completed the element part of the abnormal eye movement. We are now coming to the second part, that's the brainstem. So MLF is supranuclear connection of the third and the sixth nerve. So what happens? There is no muscle paralysis. There is only movement paralysis. So when you tell the patient to move the eye to the right side, the left medial movement is impaired because of the contralateral third nerve supranuclear connection to the medial rectus. So if the patient has to move the left eye medially, he can use the supranuclear, like pyramidal pathway reflexes are preserved. So the reflex movement of the supranuclear connection to the medial rectus can be used to move the eye left. But as we saw, Vergence movement is always bilateral. So when you have given a command to move the eye to the right side, right eye is moving, left eye is not moving. This is sensed by the higher centers, and it tries to move the left eye inwards. The only option is the Vergence movement. So the Vergence movement is exploited to bring the left eye inside. When that Vergence is used, as convergence and divergence are disconjugate movement. So the right eye also automatically moves inside. Then the cortical correction tells right eye has to remain out. It should not come inside. So this alternates, resulting in the dissociated nystagmus in one eye and failure of adduction in the ipsilateral eye. That is classical MLF lesion. Thalamus. Thalamus produces upper brainstem, that's the vertical gaze center in the dorsal brainstem, which I have elaborated in the brief review of anatomy I did in this session. So it's an elevation defect. So the eye elevation and divergence is affected because of the swollen thalamus pressurizes the dorsal midbrain. So down and in, that's a typical thalamic eye. Vertical and divergence movement are impaired. So down and in eye is the thalamic eye. And this is that person who had a deep CVT resulting in bilateral thalamic hypodensities. Next, so we have seen the MLF, we have seen the vertical gaze problem. Now we are coming to saccadic. So resting eye position is observed. Fast movement if seen in the resting eye position. It is called saccadic intrusion. So when you are fixing, if you are getting fast movement, it is saccadic intrusion. So saccadic abnormality, I have told pulse step mismatch. And so just look at the resting eye position. If there are fast movements, they are called saccadic intrusions. And voluntary shift of gaze from a straightforward target to an eccentric target. So I give two targets, straightforward target and eccentric target, and patient voluntarily moves. And then look for hypometric, hypermetric, or slow initiation or low velocity saccades during this movement. And involuntary saccade is elicited by optokinetic tape. So involuntarily you can use the optokinetic tape that during forward movement tests the pursuit, and during correction movement it tests the saccade. So if the correction movement is absent, as I said, you get the drift sign of gaze. Eye keeps on drifting in a frontal lobe disease because the frontomesencephalic saccadic pathway is damaged. So this is how you check saccade. Resting eye position, look for saccadic intrusion. Voluntarily shift gaze from straightforward target to eccentric target and see hypometric, hypermetric saccades, and look for involuntary saccades which can be elicited by octane. So pursuit, patient has to follow a light moving at 40 degrees per second or slower. A bright object moving at 40 degrees per second or slower is used to check pursuit. And okay, and I said the initial movement is pursuit and correcting movement is saccade. So optokinetic nystagmus, test both saccade and pursuit. Vergence, asking the patient to follow a finger slowly brought towards his nose. The finger is far away, bring it towards his nose. That is convergence. And testing ocular alignment in two gaze positions, fixing on a target at 20 feet and then at 14 inches. That is, at 20 feet, you tell the patient to look at an object, then quickly look at his nose. So look at the far off plane, look at the nose. That is another way of checking convergence and divergence. So first level, we saw diplopia, squint, various eye movement problems finished. So in the brainstem, you get gaze palsies. So what are all the key features? There is no diplopia. There is only one exception, that is Q deviation. Otherwise, in a brainstem gaze pathology, patient does not complain of diplopia. So if diplopia is there, it is first level, not second level. And reflex movements are preserved. We saw in the MLF. So reflex movements are preserved. So optokinetic or VOR will elicit the reflex movement. And disorder may be a gaze deviation or a gaze paralysis. So it's a conjugate movement. It may be gaze paralysis or a gaze deviation. It may be a problem of saccade or pursuit. It may be horizontal or vertical. So no diplopia, reflex movements are preserved. It is either paralysis or irritation of conjugate movement. It may individually involve saccade or pursuit, and it may be in the horizontal or in the vertical plane. So the simple equipment, optokinetic tape. So it is used to check whether a patient's blindness is organic or psychogenic. So if there is a organic blindness, optokinetic nystagmus will not be elicited. If it's a psychogenic blindness, optokinetic nystagmus will be elicited because patient is following the target. Then supranuclear or infranuclear. So if it is a supranuclear paralysis of eye movement, there is a reflex movement preserved. So optokinetic movement will be present. If it is an infranuclear, optokinetic movement will be absent. And if it is a frontal lobe where the saccade is lost, the pursuit will pull the eye in the direction of the OK and tape. That's the drift sign of gaze. If there is a pareto-occipito-mesencephalic, that is the pursuit pathway, there will be no OK and elicited. Then a congenital nystagmus where there is a wiring defect, instead of following towards the right where the OK and tape is moving, the eye will move towards the left. That is called inverse pursuit. And in cerebellar disease, the OK will show large amplitude eye movement. So these are the various uses of the simple equipment, that is the optokinetic tape at the bedside. So now to summarize what we went through. So you can have an involvement at the level of the orbital soft tissue that we call orbital cellulitis. So orbital cellulitis, there will be edema, there will be pain, there is paralysis of movement, but the neural structures like the pupil and the 5-1 will not be affected. That is orbital cellulitis, this one. Then you have got the orbital muscles and the neuromuscular junction where the neural element is involved. So pupil will be involved, 5-1 will be involved. And in the neuromuscular junction, various signs I just revised. And in the superior orbital fissure, you know that you have got the lacrimal, frontal, nasociliary branches of the 5th nerve and 3, 4, 6. That is superior orbital fissure syndrome. In the orbital apex, as you have seen, optic nerve. So it will be superior orbital fissure plus optic nerve, that is orbital apex. In the cavernous sinus, it is a neurovascular syndrome. So anterior intercavernous sinus, posterior intercavernous sinus, and these connect both cavernous sinus. So unilateral disease quickly becomes bilateral because it is neurovascular, severe corneal edema, severe conjunctival edema, then emissary veins getting blocked. So mastoid edema, that is called battle sign. So that is cavernous sinus is a neurovascular syndrome with severe corneal conjunctival edema because of the venous occlusion, and battle sign, that is mastoid emissary getting blocked, mastoid edema, and soon becomes bilateral. So in addition to 3, 4, 6, 5, 1, the vascular component will be there, plus 5, 2 can be involved. Then above, then before that, then beyond that is the brainstem. You get nuclear or supranuclear cranial nerve palsy. So this is so far, it can be orbital tissue, it can be muscles, it can be superior orbital fissure, It can be orbital apex, it can be cavernous sinus, or it can be in the brainstem. Then we will see some common conditions. What is this Gradinigo syndrome? So you got a petrous apex syndrome. It is otherwise called petrous apex syndrome. Pain in the distribution of the fifth day, because here trigeminal cavum trigeminal is here. So you will have pain in the distribution of the trigeminal nerve, and sixth nerve is next to that. So there will be sixth nerve palsy. So trigeminal pain with sixth nerve palsy is called Gradinigo syndrome. It happens in petrous apex syndrome, either inflammatory from a CSOM spreading, or due to lateral sinus thrombosis, or it can be due to metastasis. Then this is another summary what we have seen. So at the superior orbital fissure, orbital apex, and the cavernous sinus, this view is showing the various venous channels. So why the cavernous sinus is a neurovascular syndrome. Then we will see the fascicular lesions. Fascicular means the nerve has come out of the nucleus. That's a fascicular. So defects of the short part of the individual ocular muscle nerves within the brainstem after the nucleus. Nuclear lesion is beyond. So muscles, myoneural junction, fascicular, then nuclear. Nuclear defects of the oculomotor nucleus, because of the anatomical proximity, almost always both nuclei are affected. The trochlear nucleus or the abducent nucleus. So in the nuclear, we should see that there are special features which I have told. Edinger-Westphal is bilateral, Livetta palpebrae superior is bilateral, superior rectus is contralateral, superior oblique is contralateral. So individual muscle palsy, if there is ptosis, it is always bilateral. Pupillary involvement may be there, may not be there. So you can have isolated internal ophthalmoplegia or isolated external ophthalmoplegia. A nuclear superior rectus will produce contralateral elevation defect. That is called pseudoparanoid syndrome. Similarly, superior oblique also produce contralateral. Next is the supranuclear due to defects in the oculomotor pathways in the brainstem and supranuclear control. So there is no muscle paralysis, there is only movement paralysis. And cerebellar impairment leads to impaired smooth pursuit, gaze holding defect, and saccades. So these are various levels from below up we are going. So now we will come to that next level which we are just gone through, that what is this brainstem. So we saw the muscle, we saw the myoneural junction, we saw the fascicles, we saw the nuclei. Now we are coming to the brainstem. So Weber syndrome is third nerve nucleus. So there will be the 4 Ds: diplopia, divergence, squint, double vision, and drooping of eyelid. And pupil is dilated and responsive, and contralateral hemiplegia. That is due to the small infarct in the midbrain. That is called Weber syndrome. Then we have got a clot syndrome, where there is a fascicular involvement of the third nerve. So there will be a complete third nerve palsy. And there is, next to the third nerve, there is a red nucleus. So the red nucleus goes, it is a, so it will produce a horizontal action tremor. And superior cerebellopeduncule is also involved, that results in ataxia. So third nerve palsy with the contralateral ataxia and red nucleus producing an abnormal movement or action tremor is called clot syndrome. Next is the Benedict syndrome. Here third nerve palsy with the red nucleus. So oculomotor palsy, contralateral hemiplegia, and involuntary movement due to the red nucleus. That combination is called Benedict syndrome. Third nerve palsy, Weber syndrome, or it can be with ataxia and action tremor, and it can be red nucleus resulting in action tremor and contralateral hemiplegia third nerve. That's called Benedict syndrome. Then Nathanagal syndrome, that's a dorsal midbrain lesion, combination of nuclear and supranuclear gaze centers with the ataxia. So gaze involvement. So from the muscle, fasciculi, nucleus, now supranuclear cranial nerve palsy. So there's a gaze paralysis plus ataxia. That is called Nathanagal syndrome. Then disorders affecting the abducent nucleus, case horizontal gaze palsies, nuclear sixth nerve palsy. It can be isolated sixth nerve palsy or PPRF. If there is a PPR of paralytic lesion, the eye will move away from the side of paralysis. Irritative lesion, eye will move towards the side of paralysis. And ipsilateral peripheral facial palsy is an almost invariable accompaniment of a sixth nerve nucleus, because you know that the facial colliculus is formed by the facial nerve nucleus going round the sixth nerve. So nuclear sixth nerve palsy is usually clubbed with the seventh nerve, and nuclear sixth nerve palsy can be clubbed with the gaze palsy because of the PPR of which is close to that. Next, we are coming to the fascicular involvement of the sixth nerve. That is we saw the third nerve, now we are coming to the sixth nerve. So Millard-Gubler syndrome, where there is an ipsilateral sixth nerve palsy, contralateral hemiplegia, and ipsilateral facial. So sixth, seventh due to facial colliculus with contralateral hemiplegia is Millard-Gubler syndrome. Raymond syndrome is sixth nerve palsy combined only by contralateral hemiplegia, not the seventh nerve. Seventh is not there, only sixth. That is called Raymond syndrome. Then we are coming to the medulla. So lateral medullary syndrome, you can get a deviation of the eye towards the side of lesion. Right lateral medullary syndrome, you can get a eye deviating to the right side. Then you can get a ipsilateral saccades which are hypermetric. What is hypermetric? They shoot beyond the target. And contralateral saccades may be hypometric. This is because of the failure in the synthesis of saccade pursuit. So saccade and pursuit should be correctly matched and synthesized so that the eye will stop at the target. When the saccade and pursuit are not properly synthesized due to involvement of the connections from the vestibular nucleus to the oculomotor complex, when there is a brainstem in medullary involvement in the vestibular nuclear complex, mismatch in the synthesis results in hypermetric ipsilateral. Eyes will move beyond the target ipsilaterally and under the target contralaterally. And this vestibular nucleus, as you saw the various connections, it will produce a horizontal rotary nystagmus. And to correct for there is a null position adaptation by the head tilt. And there can be a vertical skew deviation where the ipsilateral eye is lower and head tilt towards the side of lesion. So because of the failure of the synthesis of the various executory eye movement due to defect in the vestibular inputs to the oculomotor complex, the eye deviates more towards the same side. There is a horizontal rotary nystagmus. There is a head tilt and a skew deviation. And the nodulus of the cerebellum, we saw that influences the pursuit system. So the eye will not remain there. So when the nodulus is involved, there is a downbeat nystagmus. It goes down and doesn't stay there and comes back. Or you can also get a periodic alternating nystagmus where it doesn't stay in the place where it should stay. Instead, it reverses the direction. Because again, the inputs from the nodulus to the oculomotor system is defective. So eye does not know where the gaze should be held. So it comes back. So either you get a nodular nystagmus or a periodic alternating nystagmus. Now let us see what is a nystagmus. It's an involuntary rhythmic biphasic oscillation in which at least one phase is always slow. So nystagmus should have a slow component and a fast component. It can be congenital or acquired. It can be physiological or pathological. It can be pendular or jerky. And it can congenital nystagmus, very not at all uncommon. Usually it is horizontal, it is pendular, and there is no oscillopsia because it is long duration and patient is adopted and it worsens with fixation. And acuity is not affected. It's not E, it is A. Acuity is not affected. And in addition, in order to adjust for the congenital nystagmus, patient can have a head nod that is called titubation. And there is a null position dampening. There is one position where when nystagmus is very less, that is the position where the maximum vision is happening. So when the eye reaches that null position, the nystagmus dampens and they have inverse pursuit. So these are the features of a congenital nystagmus. We saw what are all the features of a congenital squint. Like that, these are the features of a congenital nystagmus. And next, what is physiological nystagmus? It is symmetrical in extreme gaze, and it happens when the eye is moved more than 30 degrees. It is a very small amplitude. It is worse with fatigue, and often it is not sustained. And other physiological nystagmus are optokinetic nystagmus and vestibulo-ocular reflex, which are normally occurring in normal people. Now let us see how to differentiate a peripheral vestibular dysfunction from a central vestibular dysfunction. It's a common thing at the bedside. The peripheral patient will have severe vertigo. Autonomic features like vomiting and sweating will be severe. Usually deafness is there. The duration of illness is long because conditions like Meniere's disease. And the nystagmus, as we saw how it is produced, horizontal rotary, and fixation reduces the nystagmus. And the nystagmus will have latency, fatigability, and adaptability. And the environment spins towards the fast component, that is away from the side of defective ear, and fast pointing towards the slow component and falling towards the slow component. So when the right eye is at fault, right vestibular system is fault, means he will fall towards the right side and his environment will move towards the left side and head up on the affected side. If the right labyrinth is dysfunctional, patient is comfortable lying with the right eye up. There will be no brainstem features. Where the central, the vertigo will be mild, autonomic features are mild, deafness is not there. Usually it is stroke or demyelination, so duration is short. And nystagmus is uniplanar because it is nuclear, up gaze, down gaze, horizontal, uniplanar. And fixation does not produce any change, no latency, fatigability, or adaptability to the nystagmus, because that is a property of the fluid column in the labyrinth. That is not there in the central vestibular nucleus. And environmental spin and the fall is multidirectional. And there is no preferred plane in which patient is feeling better. And the brainstem features will be there. So now how are you going to describe an eye movement? To summarize, you should tell the resting eye position. If squint is present, see whether it is paralytic or non-paralytic. I have told you about the cover test, alternate cover test, primary deviation, secondary deviation. So if you will know whether it is paralytic or non-paralytic. If paralytic, look for diplopia and identify the muscle involved. If non-paralytic, check the afferent pathway. Vision may be affected. And if afferent is normal, check supranuclear pathway. So non-paralytic skin could be due to asymmetry in the visual acuity. If that is not there and still a non-paralytic skin is there, supranuclear pathways may be abnormal. Next, look for abnormal eye movements like opsoclonus and nystagmus. And with reference to element, what I have told that the recti or in the abducted eye, remember these key points. That's the take-home points. Superior muscle syntart, inferior muscle extart, vertical recti adduct, vertical oblique abduct, Edinger Westball and levator palpebral superior bilateral, superior rectus and superior oblique is contralateral. Then with reference to hemispheres, you have got the drift sign of Gay due to frontomesencephalic pathway where the saccade is not there. So when you do the optokinetic tape, eye keeps on drifting and inability to generate anti-saccades. So if the patient target is moving towards the right, you give a command to move the eye to the left voluntarily. That is one of the earliest signs of a frontal lobe disease. And absent OKN is because the pursuit movement is not there. That is parietal lobe disease. And this will be preserved in visual agnosia. And pursuit paralysis is occipitomesencephalic. Then midbrain syndromes, you categorize them into thalamo-mesencephalic junction syndrome, mesencephalic syndrome, pre-nuclear third node syndrome, nuclear third node syndrome, and combined pre-nuclear and nuclear syndromes. Because all this is in the, these are the 5 functional zones of the midbrain. I saw the thalamic eye, thalamo-mesencephalic, that is the dorsal midbrain. Mesencephalic, pure midbrain. Pre-nuclear, that is above the third node nucleus. Nuclear, at the level of the third node, the Warwick model is there. And combination of pre-nuclear and nuclear when there is a large midbrain syndrome. So these are the various combinations you get in the midbrain. So the thalamo-mesencephalic junction, you can have up gaze, down gaze, combined vertical gaze due to involvement of bilateral rostral interstitial nucleus of MLF. You can have selective down gaze palsy, selective up gaze palsy, combined vertical gaze palsy, Upgaze with normal VOR, that is called Collier sign, posterior commissure, skew deviation, seesaw nystagmus, lid nystagmus, that is a Pick's nystagmus. You have got a lid center in the midbrain that gets affected, lid will twitch, that is called Pick nystagmus, and head tilt due to nucleus of Gajal. This also I have discussed in the physiology. You see, in lower animals which have got a compound lens to measure the volume of a sugar solution, they tilt their eyeball, the housefly, and to know how much sugar liquid is there and how much is the depth of the sugar drop. Whereas human beings, we have got voluntary control, so this nucleus is non-functional. When there is a disconnection of the midbrain from the cortical area due to a lesion, the tilt happens. Like the housefly tilting his eyeball, we also tilt. If you go back to my physiology sessions, you will understand why this is. I am just putting the summary here. No? Then you have got the thalamo-mesencephalic junction convergence spasm, that is called a pseudo six-nerve palsy. Convergence retraction nystagmus. When there is a disconjugate matching of convergence and retraction, it results in convergence retraction nystagmus. And spasm or paralysis of convergence or divergence. Wrong way, eye moving away from the pathology side. Each one is a topic by itself. Then eye movement itself will go on for years. So I am closing it here. You have to go and read. Then in the real mesencephalic, thalamo-mesencephalic junction, we finished. Now mesencephalic, prenuclear, nuclear, fascicular third nerve. We have discussed the syndromes. Pseudo-paranoid syndrome is because of the superior rectus going to the opposite side and an inferior oblique on the same side. Bilateral elevation defect happens in the nuclear third nerve, that is called pseudo-paranoid. And INO, internuclear ophthalmoplegia, we have discussed all this. And vertical 1.5 syndrome, bilateral pupil, bilateral ptosis, and down or upgaze palsy due to involvement of the fibers descending from the mesencephalic reticular formation to oculomotor nuclei. All these bases I have already said in this, so I am summarizing this. Like midbrain has got 5 zones, pons has got 2 zones, paramedian syndromes and the lateral syndrome. Paramedian bilateral INO. So restricted adduction with preserved convergent and absence VOR. Bilateral internuclear ophthalmoplegia is the paramedian syndrome. Skew deviation with the ipsilateral eye up. And the Millet-Gubler 6th and the contralateral hemiplegia, we saw that syndrome. So in this the summary point, PPRF, the destructive lesion, I move away from the side of pathology, and you can have horizontal 1.5 syndrome, bilateral region, pan gaze freezing. Bilateral PPRF, there is no eye movement, and you have got ocular bobbing, intermittent downward jerk with slow return to the midline. These are the paramedian syndromes in the pons. Lateral pontine syndrome, 1.5 syndrome, 6th and 7th with contralateral hemiplegia, ocular bobbing due where there is a unilateral ocular bobbing due to associated gaze palsy interfering with the bobbing happening in the opposite eye and signs of vestibular involvement. These are the lateral pontine. Because vestibular is pondomedullary. Then medulla, you have got lateral medulla and you have got medial medulla. So lateral medulla, skew deviation with vertical or oblique diplopia and ipsilateral eye down. And crossed diplopia, which works during gaze to the unaffected side. And a tilt of the visual field due to tilt center from the utricle and saccule. So the environment will appear tilted as if the building is going to collapse. Patient will be very much frightened because of the fibers from the utricle and saccule to the vestibular nucleus giving wrong sensation. The environment becomes tilted. And Popper's type of lid nystagmus. So lid nystagmus, which correlates with eye nystagmus, is called Popper's nystagmus, whereas Pick nystagmus is independent lid nystagmus, which happens in the midbrain. Then you have got the nystagmus of vestibular or cerebellar type. All can happen depending on which part of the medulla is affected. Then hypermetric saccade to the affected side and hypometric to the opposite side. I have elaborated the physiology of this. And this causes ipsilateral deviation, that I call lateral pulsion of Barre. And this is due to isolation of the vestibular nucleus from the rustiform body. And medial medulla produces upbeat nystagmus due to extension to the medial longitudinal fasciculus. And cerebellum produces cogwheel pursuit, and that is pursuit is defective, so it is supported by the saccades, resulting in a cogwheel pursuit, because the pursuit is carried out by microsaccades. And gaze-evoked nystagmus, because the neural integrator is leaky, so it is not remaining in the target for the desired period of time. You can have upbeat in superior vermis and combined syndromes. So these are the various oculomotor disturbances. You can have isolated vertical saccadic paralysis. This is again summary of what I have told for the various brainstem. This is put in a gist in this PPT taken from the journal. Same only, this is summary of what I have just dealt with in the various locations in the brainstem. So eye movements are essential for optimum vision of the environment and is the precise mathematical product of the synthesis of supra and infranuclear mechanisms carried out by the neural integrator and envisioned by the whole brain. So whole brain is involved in the eye movement control. That is why so many combinations. So you have to go back and read the C and Lee textbook and make, this is the digested end product that I have given. This is the template which because of years of teaching, I have created this template. You go back and read, then you will understand it is only mathematics like the rest of the brain functions. And however, a bit of mystery always remains for the creator and a good artist, a physician, changes the simple observations into a great music that is the right diagnosis. So thank you.